Hello,
Hi.
my name is Mansi Gawali. I'm one of the medical student. So today we are going to do your complete cerebellar testing.
Okay.
What is your name?
Sunita Gawali.
Okay, and what is your age?
42 years.
Okay. So we'll start now.
Okay.
Rapid alternating movement. For arms, show the patient how to strike one hand on the thigh, raise the hand, turn it over, and then strike back of the hand down to the same place. Urge the patient to repeat these alternating movements as rapidly as possible. Observe the speed, rhythm, and smoothness of the movements. Repeat with the other hand. Show the patient how to tap the distal joint of the thumb with the tip of the index finger, again as rapidly as possible. Again, observe the speed, rhythm, and smoothness of the movements. For legs, ask the patient to tap the ball of each foot in turn as quickly as possible on your hand or the floor. In cerebellar disease, instead of alternating quickly, these movements are slow, irregular, and clumsy, an abnormality called dysdiadochokinesis. Point to point movements. Arms to finger to nose test. Ask the patient to touch your index finger and then his or her nose alternately several times. Move your finger so that the patient has to change direction and extend the arm fully to reach your finger. Observe the accuracy and smoothness of the movement and watch for any tremor. Now hold the finger in one place so that the patient can touch it with one arm and finger outstretched. Ask the patient to raise the arm overhead and lower it again to touch your finger. After several repeats, ask the patient to close both eyes and try it several more times. Repeat it on the other side. In cerebellar disease, movements are clumsy, unsteady, and inappropriately variable in their speed, force, and direction. Legs to heel to shin test. Ask the patient to place one heel on the opposite knee, then run it down the shin to the big toe. Observe this movement for smoothness and accuracy. Repeat on the other side. In cerebellar disease, the heel may overshoot the knee and then oscillate from side to side down the shin. Guide. Ask the patient to walk across the room or down the hall and turn to come back. Observe the posture, balance, swinging of the arms and movement of the legs. Walk heel to toe in straight line, called tandem walking. Walk on the toes and then on the heels. This tests plantar flexion and dorsiflexion of the ankles as well as balance. A uncoordinated guide with reeling and instability is ataxic. Tandem walking may reveal ataxia. Walking on toes and heels may reveal distal leg weakness. Hop in place on each foot in turn. This tests proximal and distal muscle strength in legs and requires both normal position sense and cerebellar function. Difficulty hopping points to weakness, lack of position sense, or cerebellar dysfunction. Do a shallow knee bend, first on one leg and then on the other. Steady the patient if you think the patient might fall. Difficulty doing shallow knee bends suggests proximal weakness, weakness of quadriceps, or both. Stance. The Romberg test. This is mainly the test of position sense. The patient should first stand with feet together and eyes open, and then close both eyes for 30 to 60 seconds without support. Note the patient's ability to maintain an upright posture. Patient stands fairly well with eyes open but loses balance when they are closed, a positive Romberg sign. Test for pronator drift. The patient should stand for 20 to 30 seconds with eyes closed and both arms held straight forward with palms up. Normally, patients hold this arm position well. Pronator drift occurs when one forearm and palm turn inward and down and is both sensitive and specific for a corticospinal tract lesion in contralateral hemisphere. Next, instruct the patients to keep the arms out and eyes shut and tap the arms briskly downward. The arms normally turn smoothly to the horizontal position. In cerebellar incoordination, the arm returns to its original position but overshoots and bounces.